Just think how much American history may have changed had his wife survived. Anybody know who this is? This is Padme, who of course died giving birth to Luke and Leia Skywalker. How the Star Wars universe would have been different if maybe Darth Vader would have just been Luke's Skywalker. Have you ever wondered in those space shows how come they don't just beam the babies out? And this is Tom Riddle, son of Mary Vaughn, and of course we all know what he became into. She died giving birth to him, and probably is grateful for it. Now, I don't bring these up to make light of maternal death. That's not my intent. My intent is to show how much maternal mortality is woven into our culture and our history. I mean, it's part of our culture. I mean, it seems like everything that you see or do, somehow or another, maternal death plays a role in it. And so to have this tremendous increase in maternal mortality rate and the associated ripple effect that occurs with a maternal death, because it doesn't just affect that family or that child, it affects her family, her community. I mean, I know those of us who have had maternal deaths on our watch know how much it affects the healthcare team. I'm still affected by maternal deaths that I've been involved in. And so it really is something that is woven into our core being, and no woman should have to die in this day and age of a child death-related trauma. And so it really is a failure of our healthcare system. But why the increase? What's driving this? Well, partly there are problems or reasons for the increase. Some are the complexities of ascertainment. I'm not going to get into this in any great detail, but I kind of alluded to it a little bit at the beginning, and that is oftentimes we're dealing with different definitions. I know in Texas, when you look at the rate increase in the Texas mortality rate, there are some people saying, well, it's not really an increase, they're just counting it better. That's not true. It's really an increase. There's delayed childbearing, there's the obesity epidemic, there's an increase in cesarean delivery, and then there's severity of maternal and medical conditions. Very much reflects what Melanie just talked about. For example, in Maryland, they had a 38% of maternal deaths that were not reported, or 38% of maternal deaths were not reported on death certificates. So there's a real ascertainment problem that we have in this country. And it's not just in Maryland, and it's not just in Virginia, it's everywhere in the country. And it's kind of embarrassing that we really can't get our hands on the true maternal death rate in this country because our record keeping is so poor. You would think something this important, we would know exactly what the number is. Part of the problem is highlighted here. This is from a paper out of CDC and Bill Callahan. And you can see how there are three different definitions of maternal mortality. This is systems of maternal mortality surveillance in the United States. This is National Vital Statistics, Pregnancy Mortality Surveillance System, and Maternal Mortality Review Committees. And they're using different definitions. Can't we just agree on one definition? So delayed childbearing. And this is looking at trends in maternal mortality in 27 states and in Washington, D.C. And you can see how this is years 2008 to 2009, this is 2013 to 2014. If you look here, this is women over 40 years of age, and this is maternal death rate. Older women are dying more commonly. Obesity. As Melanie alluded to, this is just from a study looking at obstructive sleep apnea, which is kind of a proxy for obesity. And then you can see obstructive sleep apnea is related to increased odds of preeclampsia, eclampsia, cardiomyopathy, pulmonary embolism, and in-hospital mortality. Heavier women are at increased risk. Now, the problem that we get into with this is that we become immune to it. I ask my residents who are scheduling a repeat cesarean, I'll say, well, how heavy is she? And they say, oh, she's not heavy at all. And we look up at her BMI, it's 34. We've completely skewed our vision of what's heavy and what's not in this country, and obesity certainly is leading the way when it comes to this. Obese women have much more complicated pregnancies, just in general. A lot of our referrals are only for obesity. There's an increase in the cesarean delivery rate. You know, people used to say, oh, cesareans, that's not a big deal. I mean, about a third of women in the United States are delivered by cesarean. We're getting pretty good at it, you would think. But if you look at Association of Rapid Delivery with Maternal Death, this is from HCA data that Steve Clark published, and you can see this is delivery type vaginal, number of deaths 17, primary cesarean, the rate goes up. There's 46, and then total cesarean, the overall rate is 10 times that of a vaginal delivery. Now, there are a lot of comorbidities. It's not just the cesarean itself, it's the reason for the cesarean that's probably associated with this. And so there are a lot of confounders, but still cesarean is a risk factor, and we're doing quite a bit more of those. And then severity of maternal medical conditions. This is a hard slide to read because it looks at trends in pregnancy-related mortality. It's the CDC data out of Bill Callahan's group. And this is looking at hemorrhage. This is like, I think I have to look at it here myself, 87 to 90, and then 90 to 93, and then, I'm sorry, 91 to 97, then 98 to 2005, and then on up to about 2013, which is the last one here. And you can see how obstetric hemorrhage has gone down. Hypertensive disorders, I can't read this, so it's my fault because I can't see. Oh, that helped. Infection is about the same. PEs have gone down. A lot of these obstetric-related conditions we've gotten better at. But if you look over here, what's driving the increase is cardiomyopathy, cardiovascular conditions, and cerebrovascular accidents and other medical complications. So that's what's driving the maternal death rate in this country are these chronic diseases, which is exactly what melanoma is about. And if you look at hospitalizations for severe maternal morbidity, and Melanie again referred to this in her presentation, a maternal death is one thing, but there are about 50 severe cases of maternal morbidity for every maternal death. Trying to be anonymous, but it's hard when you're right. Hopefully he's fixing the sound system. But you can see how in the United States that hospitalizations for maternal morbidity have increased so much over the years. So basically what we're dealing with is we're dealing with an older, heavier, sicker population. So it's not real surprising to me that the mortality rates have gone up. And I think it's kind of caught us a little bit unaware. Now, when you look at preventing maternal death, there are a couple ways to look at it. There are a couple of system-based approaches, and then there's some individual measures that we can take. System-based approaches, I think the key is maternal mortality review. And we're very fortunate here in that this is robust, but if you look at what Melanie's reported, that's data up to 2012. That's 7 years ago now. Is there a way that we can beef up her operation so that we can get more contemporaneous data that's a little bit more robust? Because I'm sure she tells you they do as much as they can with the money that they have. The other thing about maternal mortality review, and this is something that CDC has been working on recently, is for the maternal mortality review committees to work with the perinatal collaboratives in the state to try to go from recommendations to implementation of policies and procedures that will actually make a difference. And that's why we're here. because we're a perinatal collaborative. Believe it or not, you don't realize it, everyone here is part of this collaborative, okay? And so we all have to work together for this, and we have to figure out how we're going to do this, and take this information from the Maternal Mortality Review Committee and come up with some wise and prudent strategies that may actually make a difference. If you look at history of maternal mortality review in this country, this is the slide I was mentioning earlier. You can see how 1930s to 39 there were these maternal mortality, and I don't know if this is 1928, they have it here. This is from a study in 1969. So you can see how, a report in 1969, all these states had maternal mortality review committees back in those days, but most of them went away in the 80s because they were not having that much work and it was too costly. And now we've lost ground again and we're back behind the 8 ball. And these are some recommendations and thinking that comes out of the maternal mortality review committees. I'm not going to go into it because it pretty much covers a lot about what Melanie did. Also, all these slides are going to be posted on the VNPC website. So I know a lot of you are taking notes. That's good. It's good to take notes. But if you want to be able to refer to the slides later, they're going to be there. And Melanie's, I presume Melanie's is going to be there too. Yeah. I was going to say, I want to say that. Because that was a lot to digest. I still need to think about this. And then the next thing is levels of maternity care, levels of maternal care. This is something that American College of OB/GYN has been working in. And this is to adopt, have labor and delivery units adopt a similar kind of level of care as is in NICUs, so that you get the right patient in the right place at the right time. And these are the way these are coming out. This is birth centers, which are very low-risk patients. Then level 1, basic care. Level 2, specialty care. Level 3, subspecialty care. And then level 4, regional perinatal centers. This really does harken back to the regionalization of care, which kind of fell apart, was kind of a big deal in the 70s and 80s, fell apart in the 90s with changes in reimbursement and the like. But I think what the problem that we're getting into, and as Melanie alluded to a little bit, there are a lot of times patients who are not getting the right care, the right people at the right time. And that's one of the things that's driving this. So, do we need to do this? I mentioned that Texas did it, but Georgia and Indiana have also done it, and there may be other states that have instituted this as well. And this is something that we need to consider for our state. And then there's the whole issue of health equity and social determinants of health and health disparities. March Dimes is going to be leading the way, has been leading the way with this. This is from their preterm birth. This is about what health equity is. And that's the attainment of the highest level of health for all people. And it requires continuous efforts focused on the elimination of health disparities, including disparities in health care, living and working conditions, that is, addressing social determinants of health. And to talk about these health disparities, I think I'd like to have Leah Porsche come up and help us with this. This is her part of the talk. Leah is an assistant professor at Eastern Virginia Medical School. Actually, I was alerted to her because she was quoted in a newspaper, I guess it was the Virginia or something like that, because I guess she was asked to comment on some maternal death problems that we're having in the Tide area. And so I thought she would be well suited